right. So thanks, everyone. So I think most of you know that I practice in Lone Tree on the Skyridge campus. So that's just some logistical information. And so Becky actually put this quote up by Hippocrates on her talk. And I think for all of us functional integrative types, I think this is our goal. The greatest medicine of all is teaching people how not to need it. And today saw an article that popped up from National Geographic, and the title was Could menopause be delayed? Question mark. The answer could lead to longer lifespans for women, was the article in National Geographic. And I thought it was really great. I think it sort of makes sense. It might make more sense as we go through this talk. But one of the first things they talked about was like, can we develop a medication to delay menopause? So I feel like everything is like so big pharma oriented. It's like anything comes up and it's like, okay, can we develop a drug for that? And so I thought that was a little bit amusing, and not that that's not, the way to go or a valiant effort, but during this presentation, hopefully you'll learn a little bit about why that might be like, a pretty good thought. So I entitled this presentation, Hormone Myths, Pharmaceutical Fails, and Why Normal Lab Values Aren't Always Good Enough. So we're going to cover a lot of topics, maybe not too in-depth, but maybe enough to whet your appetite to learn more, and enough to maybe just make us all think that this whole idea of youth and health can come from in a different direction. So one of the things that we hear a lot in our practice when we start talking about hormone balancing and things like that is that people will say, I believe in aging naturally. And I think that, I completely get that. Again, we don't necessarily want a big pharma our way to health and whatnot, but it's a common, I guess, objection to the discussion of hormones. And what I ask people to think about is that in the early 20th century, antibiotics were developed. And with that came, just by the nature of the beast, longer life expectancies. And so it used to be that women would live to the age of 48, men on average to the age of 46 pre-antibiotic. And now, like more recently, life expectancy is on the order of 73 years old for men, 79-year-olds for women. And that had been declining somewhat recently, sadly to say. But so what does aging naturally actually mean in 2024? Well, like if you think about it, a lot of our grandparents or, us are going to be living half of our lives, half a century in menopause or andropause. And we call andropause sort of the male equivalent of menopause. But, you're going to live half of your life in sort of an aging state. So what does that mean exactly? Well, it means dementia, heart disease, fractures, diabetes, cancer, brain fog, anxiety, fatigue, muscle ache, joint pain, chronic pain. Like these are all the things that happen as we age. And, if you're not trying to take care of yourself for your own self, then do it for your family or do it for society. Because, if you lose your marbles and are sitting in a wheelchair in the corner drooling, whose responsibility is that? If you don't take care of yourself, you become a burden to society and to your family. So if you're not taking care of yourself for your own self, do it for others. So let's talk a little bit about hormones and why they're not scary. And I will tell you, before Becky and I started doing this in our practice, I thought it was kind of scary. From a surgeon's perspective, I'm more of a cut to cure, one you're done, and was never really interested in disease management, chronic disease, chronic illness, cancer, diabetes, and whatnot. Like if you couldn't take care of it like upfront with the one you're done, I wasn't really interested. But when you're able to take care of patients appropriately and properly and people are happy, then it's really fun to do this kind of work. So a lot of times too, when patients come in, they want to talk, like the first question is, not what can hormones balancing and whatnot do for me. It's what are the risks? So I would say that that's a completely wrong conversation to be having, meaning we shouldn't really be focusing on what the risks of hormone replacement therapy are, but we should be talking about, what are the risks of not doing hormone therapy? And we'll talk a little bit about, why this kind of discussion is pretty standard fare in a doctor's office. But we want to first kind of bust some myths. So a few of the things that I want to just say up front, so if you don't leave this conversation with anything else, estrogen does not cause breast cancer. Testosterone does not cause prostate cancer. And men and women need both estrogen and testosterone. So it's sort of a marketing myth. In the early 60s, Wyatt Earp came out with this marketing campaign where they said, take your estrogen. And it wasn't human identical estrogen. It was what's called conjugated equine estrogen, which is Premarin, which is made from pregnant mare's urine. So it was artificial synthetic estrogen. But they said, you weren't really going to maintain your womanliness if you didn't have your estrogen. So men and women need estrogen. And in fact, men and women need about the same amount of estrogen. And women will make more testosterone in their lifetime than they will make estrogen. Now, as far as testosterone goes, women need less, but women also need testosterone. Cholesterol's not bad. Antacids aren't harmless. Why wouldn't they be safe? Because you can buy them over the counter, but we'll talk a little bit about that. Medications they're not often good for me. And yes, I too can lose weight, give myself health. And normal or average labs do not mean I'm okay. So I think that's something that we see a lot in offices also, where patients will come in and say, I feel like I'm not myself. I know that something's wrong or not right. And what's the first thing that we do in the physician's office? We get a bunch of labs. They all come back, quote unquote, normal. And we let our patients know their labs are fine and we send them on their way. That's not really the best way to take care of patients. And we'll talk about that too. So one question is why would we think that estrogen causes cancer? And why would testosterone cause prostate cancer? Especially when nearly every cell in your body needs estrogen and testosterone to perform properly. So we're going to look a little bit at that. And your bodies start making these hormones in utero. So it kind of doesn't make sense that they would cause cancer, meaning, is there some point in your life you go through a change of life and all of a sudden they become cancer causing molecules in your body? That doesn't make any sense. And just a thought, that thyroid and vitamin D is also a hormone, even though it's called vitamin D, but they are on their receptors are on almost every cell in your body, even more so than testosterone and estrogen. So this is a schematic of testosterone receptor sites. So they're on 90% or more of the cells in your body. So if you look through this slide, I think you're going to be hard pressed to find some organ, some cell type where you're not going to find testosterone receptors. So you can imagine, what happens as we age and our testosterone levels start to drop for both men and women. You're going to lose bone, you lose muscle mass. Some people say that muscle is the currency of aging, and you find testosterone receptors on your prostate, in your immune system. So you need them for bone health, brain health, heart health, you name it. So when we talked about, what are the risks of hormone therapy, well, let's look on the right-hand column where we talk about not having your hormones. So if your testosterone levels are low, it increases your risk of cardiovascular disease, diabetes, cancer, all cause mortality increases with low testosterone. Now, if you look, for example, at Quest normal lab values for men and total testosterone, often you'll see those quote unquote normal lab values as being somewhere between 200 to 300 and about 1100. So if you have levels in a man of less than 600 of total testosterone, you're already at increased risk of dying. And so 600 kind of sits right in that median level, in the middle of the bell curve, and we'll talk about that. But if you're in the middle of that quote unquote normal testosterone level request, you're already at increased risk of dying. And it protects against coronary artery disease. It naturally dilates the arteries that feed your heart. You need testosterone to maintain muscle mass, including your heart. And there's a 5-time higher concentration of testosterone receptors on your heart muscle than there is on your skeletal muscle. We know how important it is for skeletal muscle mass. It increases the risk of dementia, depression, cancer, loss of bone, all those things that you see on the left side. And if your testosterone levels are low, it increases your resistance to insulin. So what's the definition of type 2 diabetes? Insulin resistance. So, if you're pre-diabetic, getting started on testosterone for both men and women will help your insulin sensitivity, and it can help you to reverse diabetes or pre-diabetes. So testosterone is not a male hormone. And in fact, the testosterone receptor gene is on an X chromosome. So you can't really argue that testosterone is a male hormone. And estrogen is not a female hormone. So again, I mentioned, men and women need about the same levels of estrogen in their system to feel good. And estrogen is a visceral fat shredder. So if you have that internal belly fat, both men and women, it can help decrease that. And we have receptors for estrogen, testosterone, and almost the same organs for both men and women. And men actually make estrogen from their testosterone. So if you think about dementia, for example, so men tend to develop dementia less often and later than women. Women develop dementia sooner and more often than men. And one of the reasons is when women go through menopause and they lose their estrogen, they lose their brain protection. Men make estrogen from their testosterone. And so even in men, if their testosterone levels are low, they continue to get protection from the estrogen that they're making from their testosterone. So that's one of the things that explains, this sort of gender discrepancy in the development of dementia. So this is a schematic of all the receptor sites for estrogen in both men and women. And again, you can see that there's almost no organ, system, or cell that does not have estrogen receptors. So if you lose your estrogen, you're going to lose bone mass, muscle mass. You're going to affect your reproduction, of course, your immune system, your cardiovascular health. So this is how important these hormones are in your body and why it's important to maintain youthful levels. So same thing. If we look at the risks of not doing hormone replacement therapy for estrogen, look in the right-hand column. So weight gain, increased risk of endometrial and breast cancer, osteoporosis, dementia, heart disease, metabolic syndrome. You can go down that list. And so when you replace these levels to more youthful levels, then people feel better. They come off their sleep medicines. They come off their antidepressants. They lose weight. And so one of the reasons women in particular, but men and women tend to increase their weight as they get older is that you need estrogen for all of these organ systems. And when your estrogen levels drop, your body goes, hey, where's my stuff? I need it for my bone, brain, heart, all of this. And so guess what? The other cell in our bodies that make estrogen are fat cells. So we gain weight as we get older when we start to lose our hormone levels because your body is very good at these compensatory mechanisms to get what it needs. So your body starts making more fat. It's happy. It's getting its estrogen. But what do? We don't like it. So we starve ourselves in exercise. Okay, well then now if you decrease the amount of fat production, your estrogen production goes down. And so what then happens? Well, your thyroid kicks in and goes, oh, I'll help. I'll slow our metabolism down so we could start gaining more weight again. So this is why you hear people saying, I'm dieting, I'm eating 500 calories a day, I'm exercising like crazy, and I can't lose weight. Well, all the things that we're doing externally is because we're completely disregarding what our bodies are needing biochemically. So it's, if you think about root cause analysis of why these things are happening, then it's very helpful to understand endocrine function and our internal biochemistry. So a couple of other thoughts. So we need to stop blocking estrogen in men. So for men who are being testosterone replaced, it was sort of very common to say, well, if their estrogen levels are going up, let's block that. And that is actually not super helpful. And then oftentimes when you see men that actually don't have enough estrogen, those are the dudes that you see in the gym, the big buff dudes with the thin hair and the big beer bellies, because they don't have enough estrogen. Increased estrogen, again, helps us to lean out. It gives us better mental clarity, helps with the blood pressure, all those organ systems that we saw affected by estrogen. And again, estrogen and testosterone having good levels helps us with our insulin sensitivity. And symptomatically, if you, particular women, but men can have these symptoms too, if you're having night sweats, often that's low testosterone, and hot flashes tend to be indicators of low estrogen levels. So this is kind of female oriented, but in 2002, on the cover of Time magazine, results of the initial results of the Women's Health Initiative study came out. And they said, we need to stop doing hormone replacement therapy in women because we're killing our women. Our mothers, our grandmothers, our sisters are dying of breast cancer. They're dying of heart disease. They're dying of blood clots. They're dying of blood clots to the heart. And it's being caused by hormones. And so this study probably did the most amount of damage of any occurrence of anything that happened in women's health in history, because all of a sudden we were yanking all of our women off of their hormones. But what they did not talk about was that the Women's Health Initiative study was done on conjugate equine estrogen, or Premarin, so synthetic artificial pregnant mare's urine estrogen, and synthetic artificial progestin. And that's different from human identical progesterone. And we're going to talk a little bit about that. So the Women's Health Initiative enrolled 160,000 women. It started in 1996. They stopped it in 2002 after, a little over 5 years. It was supposed to go 8.5 years, but the trends that we're seeing was what I just said: blood clots, breast cancer, heart disease, all of that. And so they stopped the study. Now, so we're going to talk a little bit about what the problem was. So hormones require receptors. So it's a lock and key concept. So the hormone is the key, your receptor is the lock, and you need a good fit. So the way that pharmaceutical companies make money is they patent drugs, and you cannot patent anything that's made in your body. So what they do is they change the chemical structure of hormones such that they can patent them. But you can imagine that perhaps after all these years of evolution, that really the best things for our bodies are the things that our bodies have evolved to make. So looking at progesterone, for example, on the left, and synthetic artificial progestin on the right, they're different. And that's how the drug companies can patent their product. So it actually turns out that the artificial progestin doesn't actually even bind the progesterone receptor. It actually binds the androgen or the testosterone receptor. So that's one thing. It doesn't even bind the receptor that it's designed to activate. But when you look at the differences between progesterone and progestin, what this researchers said initially was, oh, they're all the same. Progestin, progesterone, let's call them progestogens and put them all under one umbrella, because people get confused when you talk about progestin and progesterone, as they should, because they're two different things. But researchers made it even worse by saying, no, they're all the same. We'll just call them progestogens. So if you look on the right and the left, they are very different. So synthetic artificial progestins increase the risk of breast cancer. Progesterone protects against breast cancer. Progestins will cause osteoporosis, and it can be tough to reverse because your body has a hard time getting rid of these artificial synthetic hormones because it's never seen them before, so it doesn't know how to break them down. Whereas testosterone, estrogen, it knows how to break these products down and eliminate them when necessary. So progestins increase the risk of heart disease, increase the risk of stroke by 41%, increases the risk of Alzheimer's by 205%. and increases the risk of pulmonary emboli by 2,600%, 2,100%. So they're very, very different. So we're going to change topics a little bit, and we're going to talk about pharmaceutical fails. So how do a lot of these artificial synthetic pharmaceuticals work? Well, they work by poisoning enzymes or blocking receptors. And Dr. David Brownstein has written a lot of really great books that are very easy to read and understand. But he says, you can't poison enzymes and block receptors for the long term and expect a good result, because those enzymes are there for a reason and those receptors are there for a reason. So when you take these medications that do these things for the long term, then they become problematic. So let's talk about a couple examples. So cholesterol lowering drugs, or statins, is one example. So Dr. Brownstein wrote this book called The Statin Disaster, and it explains why people develop all these kind of bad side effects and things from cholesterol lowering drugs, but he also explains why they are not good. So here's a bunch of names that we've probably all seen: Lipitor, Crestor. These are all different types of cholesterol lowering medications. Okay, so the reason that lowering cholesterol is not good is, let's look at the left side. So every cell in your body is made of cholesterol. So the cell walls of every cell are made of cholesterol. Your brain is mostly made of cholesterol. There's a lot of nerves in there. All of the sheaths of nerves are coated in cholesterol. All of your sex hormones, vitamin D, your stress hormones, bile salts that are made in your gallbladder to process fats, your immune cells, they all need cholesterol to function. So one of the things to think about in terms of the brain and cholesterol is, if you look at the increased use of statins in this country and you see the increase of dementia in this country, it kind of makes sense, right? If you lower the cholesterol levels and your brain needs cholesterol, your cell wall needs cholesterol, it can become, problematic. So cholesterol is not really the problem. So you need, there's very low density lipoproteins, VLDL, LDL, which is kind of considered a bad one. HDL is considered a good one. They're kind of categorized as being good and bad, but all these cells or these molecules are made in your body for a reason. So if you think, there's sort of this firefighter analogy. So, if you see firefighters at a fire, they're there to fight the fire, right? You don't think, oh, there are a lot of firefighters at the fire, so they must have started the fire. So that's sort of the analogy with cholesterol, is that people say, cholesterol goes up in heart disease, so it must cause heart disease. That's not true. So cholesterol goes up because of things like hormone imbalance, infections, metabolic disorder, thyroid disorder, poor diet, obesity, diabetes, because cholesterol goes up in reaction to these underlying problems, which, if you think about it, kind of makes sense. So if you, for example, don't have all of your hormones, like your hormone levels are low, your body will say, oh, we need more cholesterol because that's the foundational molecule to make hormones. And so it turns out, and we see this in our practice every day, if you properly balance people's hormones, including their thyroid, give them their vitamin D, give them their sex hormones, then their cholesterol levels will actually normalize. So you want to fix the underlying problem and the lipid profile will come in line. So this is like the pathway to make cholesterol. So if you look to the right where it says poison, so statins poison this thing called HMG-CoA reductase. So it stops the synthesis of everything that goes downstream from there, including, if you look at the bottom, the bile salts we talk about are important for protein synthesis. Hormones are important, or cholesterol is important for hormone production. And this CoQ10 is used to produce energy. So if you block cholesterol synthesis, it stops energy production. And that's one of the reasons people often will develop muscle pain when they start on a cholesterol blocking agent, because they don't have the molecules that they need to make energy or ATP to feed their muscles. So again, all of these things, that the side effects that come from statins, if you read them, I mean, it makes sense because you're blocking production, downstream production of these things. So let's look at antacids, for example. So things that neutralize the acids in our stomachs, omeprazole, protein pump inhibitors, things that block histamine. So it might make your tummy feel better in the short run. So we take these things because it's symptom management, but instead of saying, oh, I wonder what I need to do to fix my tummy ache, we just symptom manage, right? We take these antacids that help to stop the tummy ache, but we don't ask, like, why do we have a stomach ache? So what's the problem with lowering your stomach acid? Well, you have an acidic stomach for a reason. So you're taking bacteria and stuff from the outside world, and you're introducing it into a sterile system. So you don't sterilize your food, basically. So if you don't have an acidic stomach, you're letting bacteria into your intestinal tract. You're not breaking down your food into the amino acids and the simple carbohydrates and things that your body recognizes as building blocks that it can absorb into the bloodstream. You can develop vitamin B12 deficiencies, mineral deficiencies, because you also develop inflammation in your intestinal tract if you're letting all these big food chunks into your system. Your body thinks those are foreign because it doesn't recognize the little molecules because they're not properly broken down, develops inflammation because you're letting bacteria into your system. So those are the problems with lowering your stomach acid. And some people say as much as 90% of examples, serotonin, or the feel-good neurotransmitter, is made in your intestinal lining. And some say as much as 90% of your immune system resides in your intestinal lining. So anything you're doing, like eating foods that you're sensitive to, if you're eating gluten and you're gluten sensitive, all of these different things cause problems, downstream problems with your immune system and your mood. So another example of drugs that are not great for us are these osteoporosis drugs. So things that are supposedly building bone. The way they work, and I say they murder osteoclasts. So this is a type of cell in your bone that breaks down old bone to allow new bone to be built. And so what these bone building drugs do is that you see an increase in your bone density. So when you go down and you get your DEXA scan to check your bone density, yes, it increases your bone density. What they don't tell you is that your fracture risk actually goes up. So it's not preventing the thing that we want to prevent, which is fractures, and it's not doing what we want your body to do, which is build new healthy bone. It's like studying for the AP test. You're not learning anything, but you're going to score well on the AP test because you studied for the test. Well, what these drugs do is increases your bone density, but it doesn't actually help you. So what is osteoporosis? Well, it's low bone mass and structural deterioration of the bone. And so the causes of osteoporosis is low testosterone, low estrogen, because you need these things as well as vitamin D, calcium, and vitamin K2 to build healthy bone. You can have an inadequate diet where you're not absorbing the minerals and the vitamins that you need. Inactivity, loss of muscle mass because you're not using the muscle to stimulate the bone. Stress could decrease bone density. So the way that bone works, there are three types of bone. There's osteoblasts that make and remodel bone. There are osteocytes that maintain your bone mineral, and you have osteoclasts that remove old bone. So bone is a live entity. And so the best way, like, for example, to repave an asphalt street is not just to fill the potholes, but the best way really to get a new street is to get rid of all the old asphalt and repave. So that's what these three bones do in unison together. They maintain the asphalt, they break down the old asphalt, they lay down new asphalt. But when you poison or murder the osteoclasts, those are the ones that get rid of old bone. So now you're just building more and more brittle bone on top of old bone. So that's why you lose the health of the bone. So the adverse effects of murdering these osteoclasts is joint pain, bone pain, electrolyte disturbances. So there are a lot of these downstream effects of killing these osteoclasts. So this is another book written by David Brownstein that I think is really great. He talks about all of these things like cholesterol lowering drugs and blood pressure medications and things like that, drugs that don't work and natural therapies that do. So he goes into detail and he cites studies and whatnot about all the things that we just talked about. So one other thing that I want to talk about is this whole concept of normal lab values. So I think a lot of patients come into doctors' offices and they already know or sense that something is not good or wrong, or they're just not feeling themselves. And so again, like I mentioned, what do we do as conventional, physicians? We love our labs. So we order lots of labs. And then when they come back normal, we tell our patients, well, your numbers look really good, so see you next year. But we haven't really addressed why the fact that, patients are coming into us because they're not feeling well. So let's think about what these quote unquote normal labs mean. It means a bell, a normal bell curve. So if we think about the general population in this country, and let's think about our weight. So the average weight in this country goes up every year. Does that mean it's good, normal, or healthy? No, it means we're fatter and less healthy. So just like we would not necessarily want our weight to be average for someone in this country, why would we want our lab values to be average? Because where do those normal lab values come from? Well, it comes from sampling this general population that we just said is fatter and less healthy. And that's where our quote unquote normal lab values come from. And then it's also broken down by gender and by age and geography. So if we lived where Ed lives on the coast, we wouldn't want our hemoglobin and hematocrit levels to be where Ed's are at sea level when we live at altitude. We need those numbers to be higher to be able to live well at altitude. And so it's also going by age. So why would I want my labs to be of a 61-year-old woman, which is how old I am? Why wouldn't I want them to be like a 20-year-old where my bone health, brain health, heart health is optimized before I've lost my hormone levels? So we really want to talk about hormone optimization or lab optimization. We want it the best that it can be so that our bodies can function physiologically in an optimal way. So we just kind of talked about this, and we want to be what's best for you. So if you look at a normal bell curve, all it says is it's a curve created by which 95% of the population is fit under this curve. So say your thyroid level is in the lowest quartile or at the lower end of normal. So that means that only 2.5% of the population has thyroid levels that are lower than yours. Now, it's also normal to live at the upper end of that normal lab value. So metabolic hormones are generally the more that and the higher the levels that you have, the better you're going to function metabolically. So if I have the choice of living in the lowest end of quote unquote normal or the highest end of quote unquote normal, my body is going to work better and feel better when I'm at the upper end. The other thing to think about is we just talked about how our population that we get these normal bell curves from is not healthy. So the whole curve is already skewed downward. Like it's already at a lower level. So if you talk about running at low levels, you're really low. If you're talking about, a normal bell curve for the United States population. So something to think about. So the Framingham Heart Study looked at the city of Framingham, and it started in 1948 and it's still going on. And they followed at that time at least 3 generations of Framingham residents. So there were 14,000 residents enrolled at that time, and they were studying patients, like looking at cholesterol levels and all kinds of different numbers to see, what are the things that affect heart disease. So Dr. Broda Barnes is a physician who practiced in the early 1900s, and he followed his patients for many, many years. And he was particularly interested in looking at people's their thyroid function. And he didn't have thyroid labs to look at. So the way he treated patients is if they had the symptoms of being low thyroid, like fatigue, waken, lethargy, cold hands, cold feet, dry skin, thinning hair, all of these different things. He actually had to function as a doctor. He had to talk to his patients, listen to what his patients said, and treat them based on their symptoms. So he would give them something called desiccated thyroid. So it's basically crushed up pig thyroid. That's essentially the same as human thyroid. And he would give them thyroid medication until they felt better. So he didn't have labs to check. So his patients had 95% lower incidence of heart disease than would have been anticipated by looking at the Framingham heart study. So, the Framingham heart study is kind of a modern study of a patient population looking at heart disease. So if you compare Dr. Broda Barnes's incidence of heart disease and what we would have expected to see in his patients, it was 95% less than what we would have expected according to the Framingham heart study. So what we're saying with this is that thyroid function has a lot to do with heart disease. So if you optimize people's thyroids and how they feel symptomatically, you can decrease the risk of heart disease by 95%. Like not 10%, not 20%, not 50%, but we could potentially lower the incidence of heart disease by 95% if we treated patients like Dr. Broda Barnes did. And that was not based on people's quote unquote normal lab values, but based on their symptoms. So it's never too early or too late to work toward being the healthiest you. So there's no point at which we can't help people to live their optimal lives. And some of it has to do with hormone balance, giving people what they need and the body what they need to function at their best levels. That's it. Question? Did I freak anybody out?